Hi, everyone. This is Professor Anderson. First of all, I want to apologize for the inconvenience for having to cancel the seminar for week 8 at the last minute. I really had hoped to feel better by 6 p.m., but unfortunately that wasn't the case. So I'm upright and feeling better now. So I'm going to go ahead and record the information from the seminar and I'll place it in an announcement. When you get a chance between now and the end of week 9, please review this information and then just submit something to the Dropbox with 3 takeaways that you had about the content of the seminar. Once again, I apologize and I appreciate your patience. Our learning outcomes for this seminar are to identify patient consent, explain patient, child, and senior abuse, describe patient rights and responsibilities, and explain policy briefs. We're going to talk a bit about what a policy brief is because one of your later assignments in the course actually asks you to locate and review a policy brief. Consent, as you know, is the voluntary agreement by someone who has sufficient mental capacity to make an intelligent choice to allow something proposed by someone else to be performed. As always, I have relevant case law to demonstrate that. And this is actually a case from 1891, Union Pacific Railroad Company versus Botsford. The facts of the case were that Clara Botsford was riding in a sleeping car on a train that was owned by Union Pacific. Some point during the night, while she was sleeping in the lower berth, the upper berth broke away and fell on her, causing grievous bodily injury. Of course, she sued the railroad. And 3 days before the case was supposed to go to trial, the railroad decided that they wanted Clara to have an independent physical examination by a physician. And she did not agree to that. So the court said, no, she doesn't have to do that. And the key finding from this case was that no right is held more sacred or is more carefully guarded by the common law than the right of every individual to the possession and control of his own person. So the issue of consent in healthcare certainly, received a lot of attention, and this was one of the landmark cases where it was first recognized. We know that there's express consent, and that's a verbal or written agreement, and that's what we obtain from our patients. Implied consent means that there's a presumption that consent has been given because of the nature of the patient's condition. For example, someone who is not conscious is not able to give consent, but they are presumed to approve treatment. It's important when that occurs, and we've seen it occur, certainly if you work in the emergency department, to document the medical necessity for proceeding with medical treatment without consent. Informed consent, we are certainly cognizant of what that means. It's a legal concept, not just a procedure that we go through in practice, and it requires that a patient have a full understanding of that to which he or she has consented. We know realistically we can't get inside our patients' heads and know exactly what they understand. What we can do is do our best to reinforce the information that was given to them by the provider about the procedure, the surgery, etc. Ask if they have any questions. Sometimes the teach back method can be helpful when obtaining an informed consent. And in general, if there is an emergency situation, if there's any glimmer of uncertainty as to what the patient would want, where again they are not able to verbalize their wishes, the situation should be resolved in favor of preserving life. We know that we have certainly standard informed consent forms where we work, but they should include things like the nature of the patient's illness or injury, certainly the name, specific name of whatever is being proposed to them as far as a treatment or procedure, why it's being proposed, certainly risks and probable consequences of the proposed treatment. Sometimes we're not able to provide patients with a probability that it will be successful. There are no guarantees in healthcare. We know that. Um, Patients need to have alternative methods of treatment and their risks and benefits, what the likely outcome would be if no treatment is given, if they refuse the procedure, and an indication that the patient understands all this. Signatures of the patient, the physician or provider, and the witnesses, and the date. And that's very important. It's certainly possible for a patient to provide consent for a procedure and then change their mind. We know that that happens, and certainly it's within their right. That's why it's so important to have the date that the consent is signed, because if a patient later decides not to have the procedure, that needs to be documented and dated as well, so that the sequence of events is clear in the record. Statutory consent is, as I stated earlier, an emergency, and in most states that eliminates the need for consent. So, patient emergency, favor preserving life. Many states have Good Samaritan laws, and in the instances, for example, where you are a healthcare provider and you are, for example, shopping or at a movie and someone experiences a medical emergency, you certainly can intervene, and you are expected to behave and respond as a provider with your level of training and expertise would provide. Typically, there is in Good Samaritan laws, limited liability to individuals who step in that situation. We know that the capacity to consent certainly has to be there. It has to be voluntary. If a patient is declared incapacitated, in many states, that has to actually be done by the court for things like mental health treatment, mandatory, or treatment, for example, to the admission to a mental health facility against their wishes, etc. But the attending physician or provider has to determine with reasonable degree of medical certainty that that patient does not have capacity. And that has to be carefully documented in the medical record, describing the reason for the incapacity and the circumstances that led the provider to declare that individual incapacitated. The needs of each patient as far as being able to consent certainly are going to vary depending on age, maturity, and mental status. Obviously, children cannot legally provide informed consent. An individual who has, dementia, or who is not able to provide consent based on current medication regimen, or any other kind of impairment, that has to be very carefully evaluated. Switching gears, just to touch on the topic of abuse, because this is something that certainly presents an ethical dilemma, a moral dilemma, and a legal dilemma sometimes for healthcare providers when we encounter abuse of patients. For example, if an individual comes to your facility and there's evidence that they have been mistreated or neglected somewhere else, what comes to mind, and not to label long-term care facilities, that's not, certainly it's not the norm, but sometimes acute care facilities will receive residents from uh, long-term care facilities who maybe have significant decubitus ulcers or other types of skin breakdown, um, and demonstrate signs of neglect. Um, Patient abuse occurs to those who are most vulnerable and dependent on others for care. Child abuse, we do unfortunately encounter that as well. If it is suspected, it is the requirement of the healthcare provider to contact law enforcement, and child protective services. Senior abuse, the same. We see, especially sometimes, patients who are cared for in the home who maybe suffer from dementia. Sometimes, we see them come in and maybe they've been neglected, or maybe there's been some emotional abuse, not necessarily physical abuse. Um, and sometimes in long-term care facilities, group homes, etc., patients are subjected to neglect and, again, verbal abuse. When I worked at the Board of Nursing, that was one of the more common um, complaints that we received. And not so much physical abuse, that was very rare, but sometimes we did get complaints, especially from long-term care or group homes, etc., of a nurse being accused of being verbally abusive to a patient or a resident. And it's not always it's not the intent of the individual who is speaking, it's the way it's perceived by the recipient. And sometimes people just are gruff, and that's their nature. But body language plays a big part of it, facial expression, tone, volume of what we say. Even if the words aren't necessarily abusive, if all the other things come together to indicate displeasure or frustration or anger at a resident or a patient, then that's how it's going to be perceived, and it's going to constitute verbal abuse. Nursing facilities should be places of hope, not hopelessness. And who says, I just can't wait to go to the nursing home? When I was with the board, I frequently went out to long-term care facilities and provided presentations to nurses about, current topics, or if a director of nursing would identify, hey, could you come talk about documentation, how important it is, etc. So I was doing that at one of our healthcare facilities, long-term care in the state. And it's a nice facility. Physically, it's very nice. But I was talking to the group of RNs and LPNs. There were some CNAs in there. And you know how you can walk in a room and start talking and just kind of feel like the vibe is off? Um, and that's the feeling I had. I felt like there was just a lot of, I don't like to use the word apathy, but it was kind of like, lady, just stop, just go away. And overall, it just seemed like there was a lot of dissension among the staff. Um, we were in a room with a glass window, and on the other side of that window, across the hall, was the activities room, and there were a lot of residents in there doing various activities. So at one point, and there was a lot of eye rolling and, that kind of stuff. So at one point, I just stopped what I was saying and I said, listen, thank you for having me, but I want everybody to look to your right, look out that window, and tell me what you see. And they were like, okay, so, well, there's Mrs. So-and-so, and there's Rose, and there's Ethel, or whatever. And I said, none of them in that room chose to be here. I'm pretty sure. You chose to be here. So this is their home. If you don't choose to be here and provide caring, supportive, helpful, kind care to them in their home, then maybe you need to think about working somewhere else. Because I just was really frustrated. And I was expecting a lot of backlash, and oddly enough, I didn't get it. They kind of looked at me uh, like deer in headlights, and um, and I went on with the rest of my presentation about documentation. And after I was finished, I looked at the director of nursing and I said, "I'm so sorry, but it was just really awkward and uncomfortable." And she said, "No, you're exactly right. Um, that's kind of where the staff was, and the residents weren't people, they were just somebody else to take care of." And I don't know that I made a difference. I probably didn't, but it just needed to be said. And that's the only time I ever did anything like that. But um anyway, nursing facilities should be places of hope, not hopelessness. And I just felt the need to say something. In terms of reporting abuse, as stated, all states have laws to protect abused children. Typically, for healthcare providers, it's mandatory. And if you report in good faith, if you have a reasonable suspicion or reason to believe that it's occurring, you are granted immunity legally for reporting. Clear documentation, photographs, wherever possible and where appropriate. Um, as I stated, if you report in good faith, your immunity is given to you, but uh, what good faith is and how it's specifically defined varies from state to state, but it generally means, once again, if you have reasonable suspicion, um, then certainly report it. It's better to err on the side of caution. These are different types of abuse, and maybe we've seen some of these occur, maybe we've seen all of them occur. Abandonment, emotional or physical abuse, psychological abuse, physical abuse, neglect, financial and material exploitation. It's very easy sometimes for patients, residents to become attached to their caregiver. I dealt with a nurse once. She was a home health nurse, and she was young and she was very pretty, very attractive, very bubbly. And she was taking care of an older gentleman in his home. His wife had passed away, and she had also cared for her years before, but the family hired her to come back and take care of him. He had some dementia, but with assistance, he was still able to be in his home. Um, it came out, family recognized at some point that he had given this nurse approximately $10,000. Um, she told him that, she needed money to help her sister pay for her college tuition, and so he was just giving her money over a period of time, and she was taking it. She put a new roof on her house. I don't know what else she did with the money, but which it doesn't matter. But the family, of course, became very upset because they did not feel that he was doing that. He was competent to make the decision to do that. Um, the nurse was, as I said, very attractive, very kind, very caring, very attentive to him. Once the money stopped, she decided that, she really didn't want to take care of him anymore. Of course, once the family intervened. Um, she talked about what good friends they were and how they were so friendly, yet she called him like Mr. Smith. So I thought, if you're that close, would you not call him by his first name? There were just a whole lot of red flags. She ended up having disciplinary action against her license because she had exploited um, this gentleman, um, his good faith, goodwill, and so as far as I know, she doesn't practice nursing anymore. Sexual abuse, it occurs, again, sometimes with incapacitated patients, and self-neglect. Certainly, if we see anything that is suspicious, that needs to be documented. Signs of over-medication, signs of mental and physical abuse of patients. You don't have to have a bruise to figure out that somebody is being abused. If a patient, for example, is very withdrawn or acts very um, tentative or scared, draws back, for example, if someone goes to touch them, and they exhibit any other kind of just really unusual behavior, then maybe and you're not sure what setting they've come from or what's happening, and they can or can't tell you, maybe it's time to investigate that further. Signs of harassment, humiliation, or threats from staff or patients, that certainly needs to be documented. You can tell whether patients are comfortable with staff, getting back to what I was just saying. Sometimes they just don't want a certain person to take care of them. If you see a number of patients who have bruises and injuries, and the elderly especially, sometimes they bruise very easily. But if you see that incidence of that increasing, then uh, you need to take a look and kind of get a picture for maybe there's a bigger issue. Patients who are left in urine or feces without cleaning. And sometimes that happens too. If you may come on day shift and night shift didn't change a patient's soiled bed or soiled depends or um, clothing, etc. And there are a variety of reasons for that. Maybe there was a huge emergency and that just wasn't priority at the time, but again, investigate it if that happens. Patient rights, we've been over this several times, but uh, certainly one of the most important here is the right to ask questions, and also the right to complain is another one. Patients sometimes don't feel like they should complain. They feel intimidated, perhaps. They're worried that if they complain, the quality of their care will be compromised. But certainly, patients need to be encouraged to provide honest feedback about what's going on with them and the quality of care that they receive. Keeping in mind that we can't always please everyone. We know that. But certainly, patients have the right to express their views. The right to know caregivers. Nothing sets me off more than someone who, y- has a name tag, but maybe it's turned around and you can't see who they are, or whether they're an RN or an LPN or CNA, and I've seen that happen. And I always ask, and you are, basically, what is your role? And sometimes, again, patients are afraid to ask that too. Um, Certainly, we know they have a right to privacy, confidentiality, um, disclosures of any information is prohibited. And, it's sometimes it's easy to, even speaking generally about a patient, like in an elevator or in this example, at a public tavern or a restaurant. Um, and you may feel like you're not providing any information that would identify that patient, but maybe they're next door neighbors at the table next to you and they're able to put two and two together. Um, so, you just have to be very, very cognizant of what you're saying to who and where. And sometimes there are patients that we do need to talk about. Uh, to get something off our chest or even to get feedback from another healthcare provider, but don't do it in a public place, I guess, or where anyone else who has ears can hear what we say. Um, Patients have the right to know the hospital's adverse events. What is this hospital's record in terms of things like surveys or accreditation, whether it's full or tentative, or the time period, or if there are things that have happened. And a lot of that is online. There are public websites that are available, like Nursing Home Compare. is one that basically gives information about long-term care facilities, including staffing and number of violations that were reported during their last inspection, um, nurse-to-patient ratios, all that. So, I was just encouraging someone the other day who's considering a long-term care facility for a family member to go to that website and shop. Basically, look around and compare the ones in the area. Not that that's 100% guarantee of the quality of care, but it's a snapshot, basically of a certain time, but it can give you an overview kind of what happened. And if a facility has significant number or a type of violations, then that's probably something that you definitely want to take as a red flag. Patients have the right to transfer. If they are able to be transferred to another facility, um, if that's their wish, then they have the right to do that. Certainly, there are times when they're not medically stable enough, but in general, patients have the right to say, I don't want to be treated here. I want to be treated at XYZ down the road. And certainly the right to access their medical records and provide access to anyone that they deem appropriate. Um, right to know hospital charges, the transparency for what the costs of care are, that's now in law, that patients need to be provided with the approximate, standard cost of, for example, how much does a colonoscopy cost? Keeping in mind that everybody's situation is going to be a little different. Some people might need additional care or, additional follow-up or something like that. But in general, what is the average cost for a patient receiving this type of treatment? Right to know medical errors. If an error occurs in their care, patients and their families, as necessary, have the right to know. That's a difficult conversation, but it needs to be had. Um, Covering things up is never a good idea, especially because there are times when patients, will ultimately, many times, learn the truth. And then for them to feel that they've been deceived is certainly not something that we ever want, because once a patient loses trust in us, it's very, very difficult, if not impossible, to get it back. The other thing is patients have friends, they have family, and especially in a smaller community, for example, word can get around, hey, don't go to this hospital because this happened to me. And reputation can have a significant impact on the not only the number of patients that you get, but, you know, bottom line, the economic impact on the facility. Patients have responsibilities too. Patients have the responsibility to maintain a healthy lifestyle, to keep appointments, to maintain current medication records, and that includes things over the counter, herbal supplements, etc. A lot of times patients don't consider that as a medication, but we know that sometimes those can interact with the prescription drugs that they're on. So we need to make sure that patients understand that if they are taking some sort of supplement, etc., that they need to disclose that when they're providing us with their medication records. Accurately describe symptoms as a whole. Leaving something out certainly is not going to benefit the quality of the health assessment that's done. So patients have to be honest and provide accurate symptoms, as well as be honest about the disclosure of their medical history. They may have something in their medical history that they are uncomfortable about disclosing, but ideally, a provider-patient relationship will be established, and the patient can be assured of confidentiality, that, whatever they say will not leave the room, and only that provider and anyone else who has an absolute need to know will know. So the patients need to be honest in general. And patients have the responsibility to adhere to the treatment plan. Granted, for example, if it's an expensive medication that they can't afford, some of these things are beyond their control. If they aren't able to keep a follow-up appointment because they have no transportation, that's certainly not something that is, you know, purposely non-compliant on the part of the patient. But if we have a patient who's non-compliant, it's important to kind of do a deep dive into what's going on. And some patients are just non-compliant. We know that too. They don't want to quit smoking. They don't want to quit drinking. They don't want to take this medication, so it's a hard thing to kind of get to the bottom of sometimes, but patients have the responsibility to the best of their ability to adhere to the treatment plan. Patients have the responsibility, if they need a second opinion, want to seek a second opinion, to do so. Again, ask questions, treat caregivers with respect. We are people too, and I'm sure we've all had situations where patients were less than respectful or family members were less than respectful. And we know that we encounter these people at an incredibly stressful time in their lives, and maybe the most stressful time they've ever had. But when we encounter that, trying to head it off as best we can without alienating the patient is the responsibility of the caregiver, and sometimes we can't. But we need to give that our best shot. Patients have to respect the rights of other patients as well, especially if, for example, if you're in a double room. Um, One patient doesn't need to have 17 family in there visiting, and hogging the TV, whatever. They need to respect each other too. Switching gears once again, we talk about healthcare policy throughout this course, and a lot of it we talk about in terms of here in the US, but we are an increasingly global healthcare environment. And the Institute for Health Metrics and Evaluation in 2023 put together a list of global health issues that they are tracking, and other agencies are tracking as well. And these are not necessarily in the order of importance, but each of them are significant. After the COVID pandemic, we, as a healthcare community, certainly became aware of individuals who suffer from long COVID, meaning those symptoms really, maybe the acute symptoms diminish, but the symptoms such as fatigue or et cetera, don't go away. So tracking long COVID and ensuring diagnostic and proper rehab support is something that is a global issue that all healthcare providers, no matter where they're located, need to be tracking. Mental health impacts of pandemics, wars, violence. We see that so much. There's so many active wars and active situations where individuals don't have food, don't have water, don't have um, adequate housing. It's heartbreaking, and the physical impacts are horrible enough. The mental impacts, uh, we don't see those on the surface, but they remain with these people forever. So tracking those um, as an important global health issue is absolutely necessary. Climate change is a global health issue. We've seen a lot of changes over the past few decades, and those are likely to continue with, um, for example, plant species or animal species that are endangered, or the melting of the polar ice caps, or the warming of the oceans, which has had an impact on coral reefs, which, determine the ecosystem of the ocean as a whole. So climate change certainly does have impact globally on health. Cardiovascular disease is the planetary leading cause of death, um, not just here in the US, but as a whole. So, tracking cardiovascular disease, treatment, uh, advances in treatment, etc., causes. Some causes are, genetic. We know that there are certain populations who are more likely to have cardiovascular disease, and making sure that those individuals, especially, are adequately um, informed and educated about healthy living, etc., as well as tracking treatment. Lower respiratory infections. We see, for example, TB in populations where there is a degree of social inequality, access to healthcare is lacking. Depending on the population, sometimes correctional facilities, we see a higher incidence of TB than we would in the general population. Um, Poverty's role in health, certainly we know that that's the case. We see that on the news every night about individuals who don't have, you know, just don't have access to healthy food. They may have access to food, but it's not healthy food. Sometimes we live in food deserts, as they call it, where, um, access to things that are healthy, like, good produce and that kind of thing, aren't there. Unfortunately, organic or, things that are more pure are more expensive than processed foods. And uh, it should be the opposite, honestly, but it's not. So if you are feeding a family and you're economically challenged, um, it's more likely that you're going to choose the processed food out of necessity. And, we really need to track if that continues to be the case and how we can change that. Strengthening of health systems. Healthcare systems across the world are so totally different in many cases. Some don't have any. Others have, access to universal health care. Some are in between. But uh, the political climate in those countries can certainly impact what the healthcare system looks like. But tracking that across the globe in developed and developing countries is important. Diabetes is certainly on the increase. Um, our population is aging, and along with that comes an increase in chronic health conditions, diabetes being one. Road injuries. Road injuries are the leading cause of death of people who are between 15 and 49 years of age. So, keeping track of that data is significant. Another thing I'll throw in here, the leading cause of death in children. When I do this live, I always ask, and I get a variety of answers. Right now in the US, the leading cause of death in children is gun violence and um, or gunshots. Sometimes it's accidental, of course. I mean, it's not all um, on purpose, but the fact that that's the leading cause of death in the US for children certainly is something else that needs to be monitored, and steps need to be taken to identify root causes and solutions. Dementia, like diabetes, certainly is increasing with our growing aging population, so tracking interventions. Adequacy of support services is significant. And in general, just our population aging. How do we adapt our healthcare system to support those of older generations? Or do we? Environmental stability, it's very simple. Everything that we need for our survival and well-being depends on our natural environment, either directly or indirectly. And to pursue sustainability is to create and maintain the conditions under which humans and nature can exist in productive harmony. Um, supporting not only present, but maintaining that support so that our future generations can be ensured of environmental stability as well. We are obligated as nurses to be environmental stewards. Um, these are just some um, very few resources that talk about environmental stewardship on the part of nurses. Certainly, the ANA's Guide to Nursing Social Policy Statement, our ANA Code of Ethics, and also Nursing Scopes of Standards of Practice published by that organization. Nursing, social nursing, or the Nursing Social Policy Statement and Code of Ethics. Those share a common theme of promoting, advocating for, and protecting the rights, health, safety of not just individual patients, but the public as a whole. And that is accomplished by providing caring and compassionate care, but also services after natural disasters or things like epidemics. Nurses can be extremely beneficial on an environmental scale, but also on a personal scale as well in those situations. So to finish up, health policy briefs. As I indicated, one of your later assignments is talking about what a health policy brief is, and assessing and reviewing and summarizing a health policy brief. So a brief, the purpose of it is to examine complex questions that are currently being debated in health policy and often in health service research. Health policy briefs provide a clear, comprehensive, and impartial overview. It's like Cliff Notes for a health policy. Um, they are briefs, and that is an accurate determination. It's so much easier for a legislator or a policymaker to read something that is concise and succinct and impartial than it is for them to read a 47-page dissertation on a topic. Because honestly, a lot people don't read 47 pages unless it's a topic that they're particularly passionate about. So the policy briefs are designed to help policymakers decide what to do and give them the information that they need in a very concise format. They also include the best available evidence that supports why policies need to change to effectively solve an issue, if that's the case. Nurses advocate by providing evidence-based, effective policies because that can ensure healthier communities. And we have a responsibility to advocate for policies that we feel are going to benefit not only our general population, but sometimes on a much much more global scale as well. Joining associations can certainly be a way for us to advocate in that way. It's important to look at an association's website, and most of them have very good public information. You don't have to be a member to access it, but look and see what association supports advocating for healthcare policies and provides resources, especially for topics or issues that you are passionate about or interested in. Policies are implemented by typically going through 5 steps. None of these is necessarily more important than the other, but they all really need to occur for it to come to fruition. Identify the need for a policy, determine what the content will be, stakeholder support, communicate it to employees or stakeholders or anybody else who is relevant. And once the policy is implemented, it is absolutely essential that not only that it be evaluated, but also updated and revised when needed. Very few policies remain relevant over a period of time, long period of time. You know, healthcare changes, policies need to change along with it. The CDC has a website there. There's a link that talk specifically about policy implementation. You have to keep the desired outcomes in mind. Know why you're doing what you're doing, keeping in mind that there may be unintended consequences. So that's something that has to be on the radar for those who are developing and implementing the policy. You have to identify the resources that can help you, whether that's financial resources or uh, personal uh, assistance, whoever you need, whatever you need. Identify what you need to help you get that policy developed and implemented. And when it is being developed and implemented, make sure that everybody involved knows their role and everybody needs to stay in their lane. So if you have a designated role, certainly it's not that you can't be helpful in another capacity, but make sure that that's in everybody's best interest if that happens. Okay. Um, Thank you again for your patience, your understanding. I will see you Thursday night of week 9. In the meantime, have a great weekend and take care, and I will see you soon.